Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCrae.
Tracy, have you ever had any numbness or tingling in your fingers?
Yes, I guess I
Let
have.
me show you which fingers. It would be the thumb,
Yes.
the index finger,
Yes.
this finger, and maybe part of this finger.
No,
Well,
I have not.
You know, people who have a condition called carpal tunnel syndrome have numbness and tingling in those fingers, and they may have some associated weakness, sort of have the dropsies. You can't hold things up.
Okay.
And it occurs when the median nerve, that's the big nerve of the three that's on the palm side of your wrist, gets squeezed in there.
Okay.
And when you squeeze a nerve, it stops working over time. And the symptoms of carpal tunnel are weakness, tingling, numbness, pain, sometimes at night. Now, there are certain people who are at more risk for getting carpal tunnel than others. People who have a little bit of a smaller canal down there to begin with. There's not as much room for their nerve. There are certain health conditions that can lead to carpal tunnel syndrome. And you know what the other one is?
No.
Being a girl.
Oh, man. The smaller. I get it. Okay.
Yeah.
Luckily for those who suffer from carpal tunnel syndrome, treatment options are available. Here to discuss treatment for carpal tunnel syndrome is Mayo Clinic physical medicine and rehabilitation physician, Dr. Jay Smith. Welcome back to the program, Dr. Smith.
Yeah, thanks for having me.
Dr. Smith, good to have you. Now, we sort of covered virtually all of the symptoms of carpal tunnel, but how do you, when you see a patient with those symptoms, how do you nail down the diagnosis?
Well, really, it's just by taking a good history and getting the history of these symptoms that you described. There are some physical exam maneuvers that are done to provoke the symptoms of the nerve irritation. And then after that, it's really a diagnosis of exclusion, meaning carpal tunnel syndrome is basically those constellation of symptoms and signs, the numbness, the tingling, the weakness in that distribution, and then making sure it's not something else, like arthritis in the wrist, like a pinched nerve in the neck, or something else.
Am I right when I said the reason why women would have it more is because their wrists are smaller?
That is one of the theories in terms of the size of the wrist, because it is a space issue. It's all about real estate.
It
not enough
pays
real
off
estate.
sitting next to these doctors.
So what is it? Can you explain that maneuver to us that might exacerbate the symptoms if you have carpal tunnel?
Well, one of the provocative maneuvers, as we say, is to just simply have your elbows on the table with your wrists bent so that your wrists are in a flexed position and your fingers are pointing towards the table. And this increases the pressure in the carpal tunnel, which is the area of the wrist that the nerve and the tendons run through. And by increasing the pressure in the tunnel, if there's limited space to begin with, the nerve will start short-circuiting, essentially, and that's when you get the numbness and tingling sensation. So reproduction of the pain, numbness, or tingling with this maneuver is one of the maneuvers we use to diagnose carpal tunnel syndrome.
Causes, we sort of talked about those. Overuse is one that I think I forgot to mention, but that's probably one of the more common causes today, isn't it? People at the computer all day long?
Yeah, it's thought to be repetitive wrist motion because when we use our fingers a lot, whether it's for playing an instrument or using a computer keyboard, the tendons are moving in and out of the hand through the carpal tunnel, and that creates friction. And that friction over time can create some tissue growth and scar tissue that then take up space, which then cause the nerve to have its own problems.
Are we getting better at the surgery to, well, not prevent, but to fix this problem?
Oh, no, surgery's a last resort, though, isn't it? I mean,
Right.
that we don't want to do that unless we have to. But
Yeah.
let's talk about some other treatment options first.
Yeah, there are many treatment options. One is if you do have an identifiable risk factor, you try to modify it. So it might just be simply modifying your workplace, modifying what you do temporarily to let the tendons swelling reduce. Certainly splinting has helped some people where we rest the wrist in a comfortable position that reduces pressure in the carpal tunnel. Many patients have specifically bad symptoms at nighttime, and it interferes with their sleep, which doesn't make anyone happy. And so there are many people that do well just splinting their wrists at nighttime. When those interventions don't work, cortisone injections into the carpal tunnel are tried and true. Many people will try one or more cortisone injections. The idea there is that the cortisone shrinks the tendons, it shrinks the inflammation around the nerve, creates more space for these things to live, and thereby reducing the symptoms. And those
Does that
are the
hurt?
mainstay. Well, not really. I mean, there are different ways to do the carpal tunnel injections, but they're generally not much more than a flu shot for most people in terms of the pain.
So are you able to do less surgical intervention than before? Was that usually where people ended up, and now you're able to not do that? as much?
I think that the standard of care treatment is still the activity modification and splinting and cortisone injections. And then when that doesn't work and people are considering surgical interventions, that's where we have some novelty in terms of new treatments, ways to do the surgery when someone has that, when they've made the jump to whatever we're doing is not working and we might need to have a surgery.
Isn't it also true that you want to do the surgery before there's actual muscle weakness?
Correct. I mean, it is a nerve problem, and the longer that the nerve is compressed, the more damage that can be done to the nerve, and the nerve may not recover once the pressure is relieved. And certainly the last thing that gets affected for most people is the muscles, and that's always the last thing to recover or may not fully recover. And then if people have superimposed problems like diabetes or people who are older, their nerves are generally not as healthy anyway, and they may not bounce back as much after a successful surgery.
What are some of the new treatments that you mentioned?
So let's assume we've tried all the easy stuff and none of it's worked. We've still got the problem.
So the standard of care surgical treatment is really to cut the ligament. The carpal tunnel is basically a space in the wrist. It's formed, the walls of it are formed by your wrist bones and then a ligament that goes over the roof called the transverse carpal ligament. And it is a space issue. So what happens in a surgery is you cut down to the ligament and you cut the ligament and unroof it, and then the tendons and the nerve have enough space to live and the symptoms usually improve.
Everything doesn't just fall out? I mean, you don't need that ligament?
Yeah, the ligament will usually scar in, so it'll kind of reform in a looser position than it used to be. And there are other tissues that are holding the tendons and the nerve in place so they don't necessarily bowstring out, which is what you're referring to. And the traditional surgical procedure is an open procedure, meaning where a surgeon would dissect down from the palm through an incision into the palm, through the fat and the tissues in the palm down to the ligament to find the ligament and then cut it. And that was really the only way it would be done for a long time until the endoscopic techniques were developed and now ultrasound guided techniques, which we can discuss, of course.
Yeah, so tell us about that. So the two surgical options are open surgery, where you actually see the ligament as you're cutting it. The other option is to put a scope in there and cut it with the scope. The results is good with that?
Yeah, the endoscopic procedures, as you mentioned, really through either one small incision in the wrist or two small incisions, you get a scope in the carpal tunnel and you cut the ligament from inside out. The results are generally the same at 1 year for the endoscopic and open, but the endoscopic people in general will have a little bit of a faster recovery due to the lack of as much trauma. It's a smaller incision. They recover a little faster. At the end of the year, they're about the same.
All right, and then your new technique.
So in the past 10, 15 years, ultrasound, as we've talked about on this show before, has really progressed, and we now have the ability to see all of the structures in the carpal tunnel under ultrasound, including the structures that our surgical colleagues are worried about cutting when they're doing surgery. So now we have the ability to place a device into the carpal tunnel through a small incision in the forearm. It's a 4 to 5 millimeter incision in the forearm, put it into the carpal tunnel under ultrasound, making sure it's placed appropriately to cut the ligament while avoiding anything we don't want to hit. And then we blow up balloons. This device basically is a 4 millimeter diameter tube that has balloons on either side. You activate the balloons, they push everything out of the way, and then the knife becomes active. And by a lever, you can activate a knife that comes up and cuts the ligament. So the idea of this is you can see everything, you put it in small, and then when you're in the tunnel, you get big, push everything out of the way, cut the ligament, and then pull out. And that's the procedure. It's an ultrasound-guided procedure to perform carpal tunnel release.
Takes how long?
This procedure would be about 10, 15 minutes.
Wow.
Yep.
And
Done.
it's quicker recovery? What's the benefit of doing it this way?
So the specific device we're talking about just came on the market in December. Now, there have been other ways to do ultrasound-guided carpal tunnel release that have been published in previous years. So what I'll tell you is based on those data. And yes, there was a prospective study done by a single surgeon who compared the open versus the ultrasound-guided technique. He did all of them. He's well-versed in both, and found that the patients he did with ultrasound guidance did have a faster recovery, less pain medication, faster recovery, faster return to activity. So similar advantages to the endoscopic, but you don't need all that endoscopic equipment, and this can be an office-based procedure.
Wow, there you go. New way to treat carpal tunnel syndrome, if you ever get it.
I hope not.
You're at risk being a woman,
I
you know.
know.
PM&R physician Dr. Jay Smith, thanks so much for being with us.
Thank you.